The worst time to take your blood pressure pill is not morning or bedtime. It is the hour when a prescription collides with the wrong body rhythm. Your doctor says, take 1 tablet daily. You obey. Every morning, the pill sits beside your coffee. The clock reads 7. The organizer clicks shut. Your clinic numbers look acceptable. Yet the medicine's strongest effect may arrive when your pressure is already falling, while its protection weakens when your pressure rises sharply. That is the hidden danger. Compliance is not always optimization. Timing, coffee, grapefruit, meals, alcohol, supplements, prescriptions, and missed doses affect a routine. So do kidney function, sleep, frailty, and medication class. A diuretic does not behave like a beta blocker. One clock rule cannot fit every patient. Consider Eleanor, 74, from Ottawa. Each morning she took 3 pills with coffee before walking her dog. After near falls, she blamed age. In this illustrative scenario, a 24-hour review showed her lowest readings matched her weakest hours. Her prescriber adjusted the schedule, and the lightheadedness eased. The lesson was not to copy Eleanor. Her routine needed to fit her physiology. In the previous video, we talked about what seniors should ask when taking amlodipine, losartan, or lisinopril. But today, we are examining the other half of that conversation, not only what you take, but when its protective window opens and closes. I am Dr. Thomas Bennett. For 25 years, I have helped older adults understand cardiovascular treatment in clear, honest language. One Spanish study, the Hygia chronotherapy trial, followed 19,084 people for about 6 years and reported a 45% lower rate of major cardiovascular outcomes when blood pressure medicines were taken at bedtime rather than on awakening. That result was striking, but it was not the final verdict. The TIME trial randomized 21,104 adults in the United Kingdom and found no cardiovascular advantage for evening dosing. Canada's BedMed followed 3,357 adults for a median 4.6 years, finding no reduction in events or death. The evidence rejects a universal bedtime command and supports individualized timing. Remember this: the safest hour is the hour that fits the drug, the pressure pattern, and the person. Do not stop, move, split, skip, or double your medication because of a general online rule. This video is not asking you to distrust your doctor or reject treatment. It is preparing you to ask a smarter question before your next dose or appointment. Comment your age and write morning or bedtime. Add explained or not explained to tell me whether anyone discussed timing with you. That helps us see which seniors are receiving a medication conversation. Today, I will walk you through 5 timing mistakes that reduce protection, worsen side effects, or create risks. You will learn how the body clock changes pressure, why drug classes need different schedules, how coffee and food matter, why water pills need special attention, and what to ask after a missed dose. We will count from 5 to 1. Number 3 makes many people stop when they first hear it. Number 5 is the quiet issue people never learn about until consequences become serious. Number 1 is hidden inside a morning routine followed by millions. Do not skip ahead. These 5 pieces interact. The answer is not simply morning or night. Here is the longevity lens you need before the countdown. First, blood pressure is not a flat line. It dips during sleep, then rises toward morning as hormones, movement, and nervous system activity increase. Second, aging reduces reserve. Arteries stiffen, kidneys clear drugs differently, and standing pressure drops faster. Third, a timing mismatch affects life beyond a number. Dizziness, bathroom trips, fainting, falls, poor sleep, and missed doses threaten independence. Office readings capture minutes. Your heart lives through 24 hours. Ambulatory monitoring can reveal high nighttime pressure, an exaggerated morning rise, or pressure falling too low during sleep. The goal is not less medicine. It is wiser medicine, the right drug for the right person at the right time for the right goal. Now begin with the unresolved question. Is an ordinary morning habit interfering with the protection your prescription was designed to provide? Mistake number 5, the morning combination that may distort what you feel. The first timing mistake may not be the pill itself. It may be what reaches your system beside it every morning. Coffee beside a blood pressure tablet looks responsible. The routine is familiar, easy to remember, and socially normal. For many older adults, that cup is also the signal that the day has begun. The mistake is not drinking coffee. The mistake is treating every sensation after coffee as proof that the medicine failed or assuming the beverage is irrelevant when the same symptoms appear repeatedly. Caffeine stimulates the sympathetic nervous system. In plain language, it presses part of the body's gas pedal, briefly increasing alertness, vascular tone, and sometimes blood pressure or pulse. A beta blocker works through a different pathway, reducing the effects of stress hormones on the heart. The gas pedal and brake image helps explain why a sensitive person notices pounding or tremor, but it is only a simplified analogy. Coffee does not universally cancel a beta blocker, and palpitations do not automatically mean the prescription stopped working. Margaret, 71, from Winnipeg, took her morning beta blocker with a large dark roast before opening her neighborhood bakery. By 9 o'clock, her hands shook and her heart felt irregular. She feared the drug was wearing off and nearly moved the tablet to bedtime herself. During a clinician-led review, she recorded the coffee amount, pulse, symptoms, and properly measured pressure. The pattern appeared on high caffeine, short sleep mornings, not every medication day. She changed the beverage routine after discussing it with her pharmacist, and the fear that had followed breakfast finally eased. Margaret is an illustrative composite, not proof of cause. Now move from her kitchen to the data. A Spanish systematic review examined 5 hypertension trials. 200 to 300 milligrams of caffeine raised systolic pressure by 8.1 and diastolic pressure by 5.7 millimeters, beginning within 1 hour and lasting at least 3. Another study found that caffeine pushed readings into the hypertensive range in 19% with high normal pressure, 15% with stage 1 hypertension, and 89% already diagnosed with hypertension. The randomized CRAVE study of 100 adults added context. Coffee days produced 51% more premature ventricular contractions and 36 fewer minutes of sleep, without significantly more premature atrial contractions. A Japanese cohort of 18,600 adults recorded 842 cardiovascular deaths across a median 18.9 years. Among participants with severe hypertension, 2 or more daily cups were associated with a 105% higher cardiovascular death risk than no coffee. That result does not prove causation or a pill interaction. Together, these studies explain why dose, symptoms, sleep, pressure severity, and sensitivity belong in the conversation. After 60, dehydration, poor sleep, arrhythmia history, slower recovery, and other stimulants narrow the margin for guessing. Ask the prescriber or pharmacist whether the exact medicine has food or beverage instructions. When palpitations, dizziness, tremor, or higher readings repeatedly follow caffeine, record the drink size, medication time, symptoms, pulse, and correct home readings for several days. Do not delay an essential dose to protect a coffee habit. Use a consistent, tolerable beverage routine and take the medicine exactly as directed. Water is convenient for many tablets, but extra water does not universally improve absorption. New, persistent, severe, or symptomatic palpitations require clinical evaluation. Chest pain, fainting, breathing difficulty, or new neurological symptoms require urgent care. Coffee may change what you feel for a few hours, but the next interaction can continue long after the glass has left your hand. Mistake number 4, the interaction that depends on the exact drug. A viewer may believe the grapefruit is already out of the body. The intestinal enzyme effect may tell a different story. This sounds contradictory. One person is warned never to touch grapefruit, while another takes a calcium channel blocker and receives no warning at all. Both reactions become unsafe when they are turned into class-wide rules. Grapefruit interactions are drug-specific, formulation-specific, and highly dependent on how much of the medicine normally passes through intestinal CYP3A4 metabolism. Picture CYP3A4 as a security checkpoint in the intestinal wall. Before some medicines enter the bloodstream, this enzyme removes part of the dose. Grapefruit contains furanocoumarins that disable portions of that checkpoint. More medicine then crosses into circulation. The image is simplified, but the consequence is real. Exposure to certain drugs rises, and dizziness, flushing, headache, lightheadedness, or excessively low pressure becomes more likely. The enzyme effect also outlasts the taste of the juice. Arthur, 76, from rural Ontario, avoided grapefruit at breakfast because his pharmacist had warned him about amlodipine. He still drank a tropical citrus blend after lunch. When he became lightheaded while carrying groceries, his family blamed heat and age. A medication review found grapefruit listed deep in the ingredient panel. His pharmacist checked the exact extended-release product, reviewed every prescription and supplement, and helped him choose a compatible drink. His relief came from identifying the overlooked detail, not from declaring every citrus fruit dangerous. Arthur is an illustrative composite, and the episode alone does not prove that juice caused his symptoms. The evidence explains why exact names matter. The official phalodipine extended-release label reports that grapefruit juice increased both total drug exposure and peak concentration by more than twofold, an increase exceeding 100%. The nifedipine extended-release label likewise reports that grapefruit approximately doubled exposure and peak concentration. Yet a controlled study in 20 healthy men found no appreciable pharmacokinetic or blood pressure effect when amlodipine was taken with grapefruit juice. Same broad class. Different interaction magnitude. A randomized crossover study of 10 volunteers adds a second citrus warning. With a 10 mg extended-release phalodipine tablet, Seville orange juice increased phalodipine exposure by 76%, while diluted grapefruit juice increased it by 93% compared with ordinary orange juice. Those numbers do not mean every citrus blend produces the same result. They show why the ingredient list and exact medication matter more than the color of the drink. After 60, slower clearance, multiple prescriptions, reduced kidney or liver reserve, and a greater consequence from fainting turn an unnoticed interaction into a larger safety problem. Ask one decisive question. Does grapefruit or Seville orange interact with the exact generic medication and formulation listed on my bottle? Check whether the tablet is immediate, release, or extended release. Read the pharmacy sheet, inspect mixed juice labels, and include alcohol, supplements, and over-the-counter products in the review. Do not stop the medication or test grapefruit at home. If dizziness is severe, fainting occurs, or weakness is accompanied by chest discomfort, breathing difficulty, confusion, or neurological change, seek urgent care. The safest synergy is a complete pharmacist-led interaction review, not automatically adding magnesium-rich foods or supplements beside the pill. If careful distinctions like this deserve a place in your daily health routine, subscribe so the next evidence-based lesson reaches you early. Then comment with the exact label question you want clarified. I read these questions respectfully, and I use them to shape explanations that protect understanding without replacing personal care. The next mistake has nothing to do with juice or coffee. It begins when a harmless-looking bathroom trip places an older adult on their feet at the least forgiving time of night. Mistake number 3. When a water pill moves the risk into the night, this one does not look dangerous. It looks like insomnia. It looks like a bathroom trip at 2 in the morning. It looks like an older person's problem. It is not. A diuretic helps the kidneys remove sodium and water. That is why people call it a water pill. Imagine opening a garden hose valve. More fluid moves through the system. Urine production increases, and pressure inside the circulation falls. The analogy is simple. The timing consequence is not. When the strongest urinary effect lands during sleep, treatment can move urgency, darkness, dizziness, and poor balance into the same few minutes. Helen, 79, from Halifax, took a fixed-dose blood pressure tablet after supper because nobody had explained that it contained a diuretic. At 2:31 morning, she hurried toward the bathroom, stood too quickly, and fell against a dresser. Nothing fractured, but the bruise frightened her into sleeping in a chair near the hallway. Her clinician reviewed the combination label, standing symptoms, leg swelling, kidney function, and daily schedule before changing the plan. Once the prescribed timing and home safety were addressed, Helen stopped treating each nocturnal trip as an unavoidable tax on aging. This is an illustrative composite. Now consider the numbers. In a 3-year prospective study, older adults reporting at least 3 nighttime bathroom trips had a 28% higher risk of an incident fall. A systematic review and meta-analysis found loop diuretic use associated with 36% higher adjusted odds of falling. Another large study of 543,572 adults aged 66 and older found that the first 45 days after starting an antihypertensive carried a 69% higher risk of an injurious fall. These studies measure different exposures, so they do not prove that one late tablet caused one fall. Together, they identify a vulnerable period where timing, symptoms, and environment deserve attention. Diuretics are not interchangeable. Thiazide and thiazide-like drugs often support once-daily hypertension treatment. Loop diuretics act more powerfully on fluid removal and are frequently used for edema or heart failure. Potassium-sparing diuretics affect electrolytes differently. Combination tablets hide a diuretic beside another blood pressure medicine. A morning dose is often practical for a once-daily water pill, and a prescribed second dose is often placed earlier in the day, but heart failure, edema patterns, kidney function, work schedules, and treatment goals change that decision. Before 10 is not a universal law. After 70, baroreflexes respond more slowly when standing, muscle strength and night vision decline, and sleep interruption produces more confusion. The risk is therefore a cascade. Urine urgency leads to rushing. Rushing follows a pressure drop. Darkness and drowsiness reduce recovery. One fall then threatens confidence and independence. Ask whether dizziness occurs when you stand. At night, sit on the bed's edge before rising, use adequate lighting, wear stable footwear, and keep the bathroom path clear. Repeated nocturia deserves review rather than dismissal. Discuss leg swelling, salt intake, sleep apnea, diabetes, prostate symptoms, bladder disease, heart failure, and the timing of every medicine. Electrolyte advice must also be individualized. Some diuretics lower potassium, while potassium-sparing drugs, ACE inhibitors, ARBs, kidney disease, diabetes, and supplements raise it. Do not automatically add bananas, salt substitutes, potassium, magnesium, or extra fluid. Ask whether kidney function, sodium, and potassium need monitoring after or a new diuretic, a dose change, dehydration, or another medicine. Fainting, repeated falls, confusion, severe weakness, very low readings, chest pain, breathing difficulty, or new neurological symptoms require prompt or urgent assessment. Do not independently move a diuretic prescribed for heart failure or significant swelling. If this is the kind of medication conversation you wish had happened when the prescription was first handed to you, subscribe. Every week, this channel turns cardiovascular evidence into questions and actions you can actually use. Changing the hour of a dose can affect sleep. Changing the number of tablets can affect far more than sleep, and it often begins with one forgotten morning. Mistake number 2, the missed dose decision that must never be guessed. You have probably done it. You miss the pill, remember later, and think, I will take 2 and get back on track. It sounds mathematically fair. 1 missed tablet plus 1 replacement tablet restores the total. Biology does not average doses that way. 2 tablets reaching the body too close together can create a higher peak than prescribed, while skipping part of a twice-daily regimen can leave an uncovered interval. A missed dose problem is not a dosing time preference. Think of blood vessels as flexible tubes whose resistance changes as medicine relaxes the wall, slows the heart, removes fluid, or blocks hormonal signals. A larger than intended dose can lower pressure too sharply or slow the pulse excessively, depending on the drug. The brain then receives less blood during standing, producing weakness, blurred vision, dizziness, or fainting. It explains why the exact tablet and formulation control the response. Robert, 69 from Calgary, worked irregular security shifts. His prescription called for a medicine twice daily, but he often took both tablets after waking because that was the only time he remembered. On other days, he took only one and promised himself he would make it up tomorrow. After nearly fainting beside his car, he admitted the pattern to his pharmacist. The pharmacist did not scold him. She checked the label, contacted the prescriber, wrote a medication-specific missed dose plan, and set up blister packaging. Robert said the greatest relief was no longer having to guess. This is an illustrative composite. The safety lesson remains the same. The population data show why reliable systems matter. A meta-analysis of 8 studies found average adherence of 91.4% with once-daily antihypertensive regimens compared with 83.2% when medicines were taken more than once daily. That does not authorize anyone to convert a twice-daily prescription into once-daily use. It shows that frequency creates a measurable memory burden. A second meta-analysis combined 44 prospective studies involving 1,978,919 participants. Only about 60% met the study definitions of good adherence. Good adherence to antihypertensive treatment was associated with a 19% lower risk of cardiovascular events, while good adherence across cardiovascular therapies was associated with a 35% lower risk of death from any cause. Association is not a guarantee for one person, but consistency is not a cosmetic detail. In a United States Medicare cohort of adults aged 66 to 79, 60.8% achieved high adherence, 30.3% had intermediate adherence, and 8.9% had low adherence. Compared with the low adherence group, high adherence was associated with a 56% lower risk of cardiovascular disease. Again, the lesson is not take extra. It is build a system that delivers the prescribed dose. Missed dose instructions differ by generic drug, immediate release or extended release form, once daily or twice daily use, time remaining before the next dose, kidney or liver function, combination therapy, and treatment purpose. The universal safety principle is narrower. Never take two doses together unless the prescription instructions or a healthcare professional specifically directs it. Check the medication guide, bottle label, pharmacist, or prescriber for the exact rule. Use a dated pill organizer when appropriate. Set a phone alarm labeled with the medication name. Mark a dose only after swallowing it. Keep pills in identified containers. Maintain a written backup plan. Ask about synchronized refills or blister packs, and involve a trusted relative when memory, vision, or dexterity interferes. An accidental double dose followed by fainting, severe weakness, confusion, chest discomfort, shortness of breath, a very slow or very fast pulse, or difficulty staying awake requires urgent medical help. Do not wait for the next appointment. For the earliest daily lessons that turn medication confusion into usable questions, subscribe here. Then write plan and leave the exact missed dose question you want discussed. I read every comment with respect and answer where general education adds value, while protecting the boundary between public guidance and personal medical care. The second biggest mistake is taking the wrong number of tablets. Number 1 is more deceptive. Taking the correct tablet at the correct dose every day and still assuming the clock can never be wrong. Mistake number 1, believing one clock time is safest for everyone. This is not a minor optimization. It is not a lifestyle trick. It is the question of whether the medication's strongest coverage matches the hours when the individual patient needs it most. Here is the uncomfortable truth. A person can take the correct tablet at the correct dose every day and still follow a schedule that has never been reviewed against symptoms, sleep, drug duration, or the full 24-hour pressure pattern. The mistake is not morning dosing, it is not bedtime dosing, it is allowing a population headline to replace an individual medication review. Blood pressure follows a circadian rhythm. It commonly falls during sleep and rises around waking as cortisol, sympathetic activity, movement, and daily demands increase. Some people do not show the expected nighttime dip. Others have nocturnal hypertension. Still, others fall too low during sleep or become dizzy when they stand. An office reading is a photograph. Ambulatory monitoring is a 24-hour film. Medication design adds another layer. A long-acting tablet often provides stable coverage across morning and evening. A short-acting or twice-daily medicine depends more heavily on spacing. An extended-release formulation is not interchangeable with an immediate-release one. A diuretic taken late can disrupt sleep, while another patient's nighttime pressure pattern requires a different clinician-directed strategy. For a shift worker, biological morning starts after waking, not automatically at 7 o'clock. Dorothy, 76, from Halifax, had acceptable clinic readings and took her long-standing prescription every morning. She also woke with headaches, became unsteady after lunch, and assumed both problems were age. Her clinician ordered 24-hour ambulatory monitoring rather than guessing from 2 office numbers. The record showed when her pressure rose, when it fell, and when symptoms overlapped. Her complete regimen, kidney function, sleep, and medication duration were then reviewed. The lesson was measurement before movement. Dorothy is an illustrative composite. Her eventual plan is not a schedule for anyone else. Now we reach the evidence chapter that changed this debate. The Spanish Hygia chronotherapy trial included 19,084 adults with hypertension and followed them for a median of about 6.3 years. Investigators reported a 45% lower rate of the composite cardiovascular outcome in participants assigned to take all blood pressure medicines at bedtime rather than on awakening. Pause. That result was dramatic. It was also not the final verdict. The United Kingdom time trial randomized 21,104 adults. The primary outcome occurred in 3.4% of the evening group and 3.7% of the morning group, a difference that was not statistically meaningful. In other words, the large reported advantage from Hygia was not reproduced. Pause again. Canada's BedMed trial then randomized 3,357 primary care patients with a median follow-up of 4.6 years. Major cardiovascular events or death occurred in 9.7% assigned to bedtime and 10.3% assigned to morning, with no significant reduction. BedMed Frail studied 776 frail older adults, whose median age was 88. Its primary outcome rates were 40.6% with bedtime use and 41.9% with usual care, again showing little or no timing effect on major benefits or harms. International hypertension experts reviewed 8 earlier bedtime outcome studies and judged all 8 to have major methodological concerns or a high risk of bias. That does not erase Hygia. It places the 45% headline inside a conflicted evidence record where later randomized trials support choice based on medication, tolerability, and individual circumstances rather than a universal bedtime command. This is the reversal many viewers do not expect. Bedtime is not automatically the answer. Morning is not automatically the danger. After 60, the decision becomes more personal because falls, glaucoma concerns, kidney function, heart failure, sleep disruption, nocturnal urination, multiple medicines, and reduced physiological reserve change the cost of a poorly matched schedule. A person with nocturnal hypertension differs from someone whose pressure drops excessively during sleep. The schedule that is followed consistently is often safer than a theoretically perfect schedule that is repeatedly missed. Bring 3 questions to the prescriber or pharmacist. First, does timing matter for the exact medication and formulation I take? Second, do my home readings or symptoms show that my pressure is high or too low at a particular time? Third, would structured home monitoring or 24-hour ambulatory monitoring help us decide whether my schedule should change? When several medicines are taken, add, should any of them be separated rather than swallowed together? Do not switch tonight because of this video. Do not split an extended release tablet, relocate a diuretic, or copy another patient's bedtime plan. Seek urgent help for fainting, chest pain, breathing difficulty, severe weakness, inability to remain awake, or new neurological symptoms. The most dangerous time is the unreviewed time, the schedule that does not match the prescription, the person's physiology, or their ability to take the medication consistently. Pause. That is the real answer. Consistency protects treatment. Measurement reveals patterns. Personalization connects the two. The 4-question medication timing protocol. Before your next routine appointment, complete 1 medication timing audit. Write the generic name of every medicine, the dose, formulation, prescribed frequency, current dosing time, and every food or beverage instruction. Record what you currently do after a missed dose. Add dizziness, palpitations, nighttime urination, falls, swelling, unusual fatigue, and several properly measured home readings with dates and times. Then ask 4 questions. 1. What problem is this exact schedule designed to solve? Daytime pressure, nighttime pressure, symptoms, fluid retention, or reliable adherence? 2. Which findings would justify changing the time, and which would justify changing the medicine, dose, or formulation instead? 3. What monitoring should happen first? Home readings, standing readings, pulse checks, laboratory tests, or 24-hour ambulatory monitoring? 4. What is my written plan for a missed dose, a repeat low reading, a concerning symptom, or an accidental extra dose? Bring the bottles, pharmacy sheets, and audit to the appointment. Do not post a complete medication history or identifying medical information in public comments. Most importantly, do not change the schedule solely because of this video. The audit turns a vague habit into a precise clinical conversation. Ending. Good medicine does more than improve a number. It helps an older adult live with steadiness, energy, and independence. This video was not designed to prove that morning is dangerous or bedtime is safer. It exposed 5 mismatches: caffeine obscuring a symptom pattern, grapefruit being treated as universal or irrelevant, a diuretic schedule increasing nighttime risk, a forgotten dose being solved by guesswork, and 1 clock time being declared best for everyone. These pieces work as a system. Interactions change exposure. Diuretics change fluid movement. Missed doses change coverage. Circadian rhythms change what the body needs. The safest plan connects them to the exact prescription. Taking blood pressure medicine is not failure. It is a valuable medical tool when selected, monitored, and taken appropriately. Aging changes reserve, but your body is not broken. Confusion, unnoticed interactions, inconsistent dosing, and unreported symptoms deserve investigation. Which mistake surprised you most? And what exact question will you ask your doctor or pharmacist? Add your age, dosing time, and whether anyone explained it. Do not post private records or a full medication list. Subscribe for physician-led explanations that separate dramatic headlines from questions you can safely use in a real appointment. Like this video if the audit gave you a practical step, and share it with someone managing several medicines. I am Dr. Thomas Bennett. This is the medication conversation that deserves more than the few seconds available when a prescription is handed across the desk. Consistency matters, personalization matters, the exact medication matters. No general video replaces your prescription instructions. Protect the routine, ask the question, and move forward with confidence.